This is Going Under, Anesthesia Answered with Dr. Brian Schmutzler. I am your host, Vahid Sadarzadeh, and as always, we're doing a Q&A and a main topic with our guy, our resident expert here for more than 2 decades in the medical field, Dr. Brian Schmutzler. Brian, how you doing?
Doing well today. How are you?
Awesome. I am doing very, very well. Of course, in our last couple episodes, we have delved into the history of your background and, touched on what anesthesia is just a little bit, but today we're going to dive into more of that history. What is anesthesia? Has it changed over the years? And also, people wanting to know how much it costs to become an anesthesiologist. It's not free, right? Nothing in this world is free anymore. So let's just dive into just give us the definition of what anesthesia is, and start there, and then the background of how it came to be.
Yeah, so anesthesia is essentially rendering someone without any knowledge or pain or anything like that of a procedure, right? That's kind of what anesthesia is. And so, you think of modern anesthesia, most people think of general anesthesia. Put a patient to sleep, put a tube in, wake them up at the end. So historically, though, and I will want to preface this by saying this is not a complete historical evaluation of anesthesia. I'm just going to kind of give you the highlights. We actually learn about this a little bit in residency when we go through and learn anesthesia. But, basically for thousands of years, people have been trying to figure out how do you make somebody not hurt and not know what's going on, right? And so you go all the way back to, the earliest recordings in Egypt, thousands of years ago. People were using all kinds of different stuff to try to get people to not know what's going on. They had a broken bone, they're having pain, we want to set that broken bone. Even the Egyptians were trying to use things. Probably the earliest anesthetic that's recorded is morphine or the opioids. People had opioids way, way, way back when, and so they'd give somebody an opioid and then try to do a procedure with that. That's not really modern anesthesia. That's more analgesia or rendering people unable or reducing their pain, unable to feel pain or reducing their pain. So you kind of move forward. There were a lot of things tried between the times in ancient Egypt to now. And so you look kind of the mid to late 1800s, and you start getting people working on the chemistry of inhaled anesthetics. And so some of the first anesthetics out there were ether and chloroform. Those are 2 things that people probably recognize the names of, but don't really know much about. Honestly, those are the precursors of our modern inhaled anesthetics. Right now we use inhaled anesthetics by the name of sevoflurane, isoflurane, desflurane. You look back to ether and kind of in between was halothane, which nobody really uses anymore. But you look back to ether or chloroform; those were kind of the precursors to those medications. Really what happened was there was kind of a coming together of a lot of different fields that resulted in anesthesia becoming a thing. So you've got the dentists, because they were doing procedures in their offices trying to take out teeth. You've got the chemists, because they were working on actually creating the medications. And then you've got the surgeons. And so all these people kind of came together. And throughout the 1800s, there were several of these. I think William Horton was one, but several of these people who came together and figured out that they could use a lot of these things for anesthesia, particularly the inhaled anesthetics. Now, a lot of patients died, and while they were trying to figure out how much to use, a lot of patients also had essentially no anesthesia when they started given these inhaled anesthetics. I mean, ether's dropped on a mask, and so it's really hard to titrate. Chloroform, as you probably know from the movies, you give too much chloroform, you can kill somebody with that. So it was a very inexact science. You kind of get into the mid 1900s, and things got a lot more clear, right? Science got better. The advent of intravenous lines helped a lot. And then with that, there was a lot of improvement in the intravenous medications as well. So, you take that from sort of the mid 1800s to the mid 1900s, before anesthesia really became a specialty. Here's the other kind of interesting thing we learn about. Usually the person doing the anesthesia for a surgery was a surgery resident or a medical student. So, early 1900s. And so they just basically said, hey, give some of this medicine or give some of this inhaled anesthetic and then they tried to do surgery with that. I don't remember the exact time that anesthesia became an actual profession, but at that point, we got training in how to do actual anesthesia that we kind of modern anesthesia we do now.
Is this written in like books? I mean, do they give you this stuff to study? Like hieroglyphics say that this is what they used for the Egyptians back in 3000 BC. Like, is that? They teach that?
They do. So there's a gigantic book that we all get as residents called, it's by the author Barish. I can't remember what the name of the book is. I guess something anesthesia and something practice. I can't remember. And I'm sure somebody will comment. Anybody who's gone through anesthesia residency is going to know this book. So, the first 200 pages of this gigantic book is just talking about the history of anesthesia. There's a little bit on our board exams, just kind of the basics, ether, chloroform, that sort of stuff. But yeah, we learn about it in residency for sure.
Man, I mean, it's a complex profession, and anybody you ask, right? I mean, let's not get away from the topics, a ton, but anybody you ask is so interested in anesthesia because they think there's so much pressure.
There is.
On the actual doctors, right? I mean, and so you have to learn about the history in order to better the future history, I guess is what you could say.
Yeah, I mean, those who don't learn from the past are doomed to repeat it, right? So we learn a lot of things in medicine and in anesthesia from bad things that happened or bad results. Not that there was any intention in that, but if you get a bad result, you always go back and figure out why. A lot of people compare anesthesia to the aviation industry, right? So there's a lot of parallels. We have to be perfect, right? I mean, if you mess up, if you mess up when you're, let's say, filing an insurance claim, right? The worst thing that happens is somebody doesn't get paid for that insurance claim, or the insurance claim is wrong and it can be fixed on the back end. If you're a pilot or you're an anesthesiologist and you mess up, that's potential for death, right? So we essentially have to be perfect.
Brian, I don't know what you're talking about. I've never not been perfect here.
Of course, yeah, exactly.
If I forget a microphone, there's no podcast.
Correct. But we can do it tomorrow.
But we can do it again.
Tomorrow.
Right? Yeah, you can do it again.
And so the other thing that's similar to the aviation industry is the three phases of anesthesia kind of match the three phases of flying an airplane. So induction is essentially takeoff in an airplane. Maintenance is when you're cruising altitude in an airplane. And then emergence is when you're landing the airplane. And so, again, it's kind of a joke in anesthesia, but it's 5% terror and 95% boredom is what a lot of people say, right? So putting a patient to sleep and waking a patient up is that takeoff and landing.
And you've got 90 minutes in between, right?
Yeah,
or whatever
it depends what the case is. Yeah, and then everything in between, almost all the time goes perfectly well.
Yeah.
You sit there, you monitor vital signs, you pay attention to what's going on in the procedure. But yeah, the going to sleep and waking up, induction and emergence are the two times that are most dangerous in an anesthetic.
So as we're talking about the history of anesthesia, talk about, maybe the 40s, the 50s, what started to happen as it became a profession. Yeah. What started to happen as it goes from, maybe you're a dentist and you did it yourself, and now you're hiring specific. Did it take a while for other physicians to catch on to this?
I think so, yeah. And we're only speaking about the MD, the anesthesiologist. The CRNA path is a little bit different. We can talk about that on another podcast, but I'm obviously not as familiar with that. So maybe at some point we can have a nurse anesthetist come on and they can kind of tell us the nurse anesthetist history. But so the early to mid 1900s we're talking about. Now it's we're developing things that make it much more specialized, right? And all of medicine was specializing at that time, right? You had general surgeons who weren't just being general surgeons anymore. They'd go and specialize in a specific area of general surgery, or orthopedists who would specialize in a specific area of orthopedics. So the anesthesia residency started, and when they initially started, they were only pretty much a 2-year residency. Well, talking or even earlier than that, I believe it was IU, which is where I trained. The anesthesiologist would just go through 2 6-week courses. Same thing over, 2 6-week courses, 6 weeks, and then the same thing 6 weeks again, and then they'd be anesthesiologists. So any of that may be an urban legend. I don't know all the truth or lies about that, but that's at least what people say. And so now you take that, and it was a 2-year residency, and now then it became an internship, which everybody's forced to do. where you kind of learn all of the medicine stuff, and then 2 years of anesthesia residency. Now it's an internship and 3 years of anesthesia residency. And the reason they did that is because there's so much specialization in anesthesia now. And I think we talked at some point a little bit about this. You can go into ICU, so critical care, pediatrics, chronic pain, acute pain, obstetrics, open heart. There's even neuro fellowships now. So essentially in that third year, we learn a lot about all the different specific specialties and fellowships you can do out of anesthesia.
You know, as a regular patient, that somebody doesn't know a lot about medicine, but I'm learning every day from you, I think that a lot of people have the impression that anesthesia or anesthesiologists or the study of anesthesia in medicine is the most mystical medicine there is, right? Like I think it's misunderstood. Like people don't understand it. You know, people understand what surgeons do or,
right.
You know, what family practice doctors do, but I think there's a lot of mystery still around anesthesiology and like what the drugs are and how they're used. So, I mean, did you have, as you're picking your profession here in medicine, did you have those kind of questions? And are you still answering questions like that? And what do you say to that?
Yeah. So, I mean, we talked a little bit on one of the podcasts about how I have a PhD in neuropharmacology. So obviously, you know, learning about the way that these drugs work, physiology, pharmacology, that sort of stuff fits really well into anesthesia. I think part of the reason that anesthesia is a black box to a lot of people is, number one, you know, most patients meet us the day of surgery and then never see us again, right? So they just think they walked in, somebody put me to sleep and woke me up, but I don't know who that guy is. And the other thing is that the medicines that we use, we don't really know how they work. You know, there's a lot of the medicines, you know, if you're talking about opioids, right, we've known how those work for, 100 years, 200 years. But, you know, the inhaled anesthetics, there's not a perfectly described mechanism for that. Propofol, which is, you know, a medicine that a lot of people know, what we use as an IV anesthetic to put patients to sleep and keep them asleep. Nobody knows how that works. There's a lot of theories, but there's no proof of how that works. So I think that kind of adds to it. And then, you know, we as anesthesiologists are usually pretty quiet, right? I mean, I'm not going to walk in and be super boisterous and, you know, you got to remember who I am. And, you know, a lot of times patients just don't know who we are. So I think that adds to it as well.
Adds to the mystery.
Yeah, the mystery of
anesthesia. The mystery of anesthesia. Where do you see, I mean, talk about today's anesthesia world. Mm-hmm. What are you discussing with your other anesthesiologist colleagues? And where do you think the profession is headed?
Yeah, that's tough. So, I mean, as in a lot of industries, there is a big demand and a small supply. So COVID caused a lot of people to retire. Honestly, a lot of people in the anesthesia world passed away from COVID infections. And so you've got a huge, huge demand. You've got an aging population who all need surgery, all kinds of different surgery. You've got a lot of surgeons taking their cases away from hospitals and into surgery centers because the cost is less expensive in a surgery center. And we've gotten so good at anesthesia and so good at surgery that typically you don't have to stay in a hospital to have surgery anymore. So now you've got more anesthetizing locations and you've got far fewer anesthesia providers. So that's the biggest thing is recruiting, retaining. How are we going to cover all this that we need to cover? And so, you know, there's obviously other anesthetists, other people who do anesthesia, CRNAs and AAs. But even if you add all of us together, there's just not enough of us. So the quintessential issue in anesthesia right now is staffing. How do we make sure that we have enough people to do all these surgeries?
How do you do that?
Yeah, well, nobody's got the secret sauce right now, I don't think. There are a lot of anesthesia providers, and I'm not blaming anybody for this, but there's a lot of anesthesia providers out there just looking around trying to find how can I make the most money. Because there's such a shortage, right? Supply and demand. There's such a shortage. There's a lot of anesthesia providers who will say, I'll go to, Lincoln, Nebraska if you'll pay me 3 times more than I'm making in South Bend, Indiana. And so that's really what's happening is there's people shifting all over the place and doing what we call locums or PRN work. That makes it more expensive, number one, and tough to keep people at a certain practice. So that's the quintessential, just worst probably problem we have in anesthesia right now.
Is the cost So let's do a cost basis
Sure,
analysis
sure,
here, okay? We're going to turn into finance guys
All
here.
right, all right.
And
It's
put our thinking cap on.
It's
right?
almost tax season.
Yeah, exactly. So we'll talk about the cost to become an anesthesiologist, but is the cost basis analysis not worth it for some of these hospitals or these systems? Like, is the cost of becoming an anesthesiologist going up? So the price that they're asking for, is it too much?
I don't know that the cost of becoming an anesthesia provider, either a CRNA or an anesthesiologist, is that much more than it was. I mean, there's, obviously year over year increases, but, the average person, so if you're going to be an anesthesiologist, you're going to do 4 years of undergrad. The average person, I don't know the exact numbers, but let's just throw it out there, $30,000 a year, right? $40,000 a year that people are spending on college. So you've got 120 to 160,000 right there. Medical schools, if you're talking about a state school, you might get away with $30,000 or $40,000 a year. You're talking about, Harvard or Hopkins or something like that. You're probably $75,000, $80,000 a year for medical school. So there's another 4 years. So you're $320,000 on that, plus 120 to 160,000 on undergrad.
Yeah.
So that's 8 years that you're $500,000 in debt, and those are years you've made zero money. Right, so you've got
like for sure zero money.
Zero, yeah. I mean, there's no way that you can work and be undergrad. I mean, I guess you could do some work in undergrad, but you've got undergrad and then medical school that you don't have any time to.
So the response to that is, well, can't you just make that up in 1 year and pay off your or 2 years, right?
Sure, but you've got 8 years where you made zero money.
Right.
So you take the average. Let's say the average person in the United States makes $50,000 a year. That's $400,000 in lost opportunity costs for that. 8 years.
Right.
And then you've got 4 years of residency after that.
Right.
Where you can do some moonlighting, but it's hard to do a lot of extra work there. I think the average resident makes about $70,000 a year. Okay. But then you have all that debt that's accruing interest on top of it, right? So even if you said, okay, I'm not going to spend a dime my first year that I'm attending, and I make $500,000 a year, you could pay $500,000 a year off in debt, but with the interest after that 12 years, you're probably at what, 700, 750?
Yeah.
So it's expensive. I mean, it's expensive to become an anesthesiologist. Now, there's some things you can do. So luckily, for instance, I had a scholarship to undergrad.
Which normally now costs $75,000 a year.
Because of where I went.
But I will tell you that they are pumping out the most doctors in the United States on average.
Notre Dame is?
Yes.
Wow.
I saw that stat that they are, I mean, it's less than a percentage, but if you look at all the other schools around this country,
nice.
The University of Notre Dame has the most doctors per.
Well, there you go.
But it seems like a small percentage, but for Notre Dame, who doesn't have a medical school,
yep,
that's a lot.
That is, yeah. I mean, Notre Dame partners with Indiana University, and they have a medical school campus up here, but they don't have their own medical school. That's actually, I mean, that's a great recruiting thing to have Notre Dame do. Come to Notre Dame, you're more likely to become a doctor.
But I mean, let's be honest, Michigan is not a inexpensive school either,
no,
right?
Not,
I mean, these public schools are becoming very, very expensive. So you're right. So you're spending like $500,000 to $750,000 over the course. How much when you go into residency then on average?
Yeah.
How much time does it take to recoup that money?
So if you took loans to do undergrad and medical school, I mean, most people pay off those loans. I mean, so you have to pay some of it in residency, but it usually takes people 25, 30 years to pay those loans off.
Did you have, were you also, so you got an undergrad scholarship. Yeah. Did you also have a scholarship to med school?
Well, I did because I did an MD PhD. So at the time, it wasn't funded by the federal government. Now IU's program is called a medical scientist training program, but it was an MD PhD program that was funded. So I did not have any debt from medical school either, and I got a small stipend on top of that to be doing the research. So
if the roles were different now, like if you had to pay for it, like if you were in debt and had to do it that route, would you still do it again?
Ooh, that's a tough question. Maybe. I mean, I think I probably would. I like what I do, especially now. I like kind of the position I'm in. I probably wouldn't have gone to Notre Dame if I didn't have a scholarship. I probably would have gone to a state school. But, to save some money. But going to medical school would have been expensive regardless.
So if you're out there wondering why, or do anesthesiologists make more money than the average family practice doc, there's a lot that goes into it that we may not understand, right? I mean, there's costs that you have to recoup through years of training.
Yeah, there's an additional year of training for anesthesia versus family practice. I mean, part of it is the way that our insurance structure in the United States is set up. Insurance companies and Medicare and Medicaid pay for procedures. So when I'm doing a procedure, that's earning more money than a family practice doc who's seeing a patient in the office. Now, you can argue whether that's fair or not. That's not what I'm here to do, but that's why anesthesiologists get paid more than family practice docs. I'd say also there's, the reason that procedures are paid higher and the reason that anesthesiologists are paid higher is because the risk, my daily risk in putting patients to sleep and waking them up, is higher on an average patient basis than a family practice doc who's seeing patients in an office for, and I'm not minimizing, our family practice docs do a great job,
right?
But, who's seeing somebody for, well child visits or, a cold or, just standard stuff like that. So there's a risk level to that then results in higher pay, just like somebody who is in an oil rig in the middle of the ocean makes more money than somebody who is in an office, sending emails.
What is the risk of being sued? Like,
oh yeah.
So, does that go up in is it they're suing the hospital system in general, or how does that? We can probably talk about an entire podcast like that, but. In short, how does that?
So it's state specific, whether you're more likely or less likely to be named in a lawsuit. In general, in the United States, a patient will just sue everyone. If they have a bad outcome or a perceived bad outcome, they sue everyone. So they'll sue the anesthesiologist, the surgeon, all the nurses in the room, the hospital, the people who are on the floor, the hospitalist, the nurses in PACU and pre-op, and everybody gets sued, and then they kind of figure it out on the back end. How likely are you to get sued? It kind of depends.
Mm-hmm.
Some of the data would say that the better relationship you establish with a patient, the more honest you are with them, the less likely you are to get sued. I don't know.
That always doesn't factor in, right?
Not always. In Indiana, it's interesting, though. In Indiana, so anybody can propose a suit, but before it actually goes to full-on lawsuit, right, where it's not just a proposed claim, it's an actual claim, there's a 3-physician panel who goes over all of the information from the case and gives a professional opinion as to whether they think it is malpractice or it isn't. And in Indiana, I can't remember what the percentage is, 95% of the time, whichever side that panel sides with, they settle, right? So if they say, yes, there's likely malpractice here, the physician settles. Or if they say there's likely not malpractice here, then usually the claimant, the patient, doesn't take the lawsuit all the way, or doesn't take the proposed claim all the way to a claim. Mm-hmm. So that's a protection in Indiana. There's also the Patient Compensation Fund in Indiana, which protects physicians from being sued for millions and millions of dollars and losing their livelihood.
We're going to talk specifically in the next podcast, in the next episode, about anesthesia and how insurance works specifically for anesthesia. We're also going to touch on some news topics, specifically the Change Healthcare hacking and what's been happening there. So that's coming up in our next podcast. We're going to finish off this podcast, Brian, with some questions that we received. One specifically from our last episode.
Oh, wow.
We were talking about about not eating before a surgery, or not eating before you receive anesthesia, and how important that is. And we were talking specifically about bronchoscopy, and you said that you've really had to deal with that in a major case only once in your career.
Right.
But talk about bronchoscopy. We had a question on Facebook, and this person was asking if it's an elective. Do you do it as a preventative? And if not, what are the certain cases that you use it for?
Yeah, so the bronchoscopy I talked about was an emergent situation, right? That patient had food particles in their lungs. I needed a pulmonologist to come in, put a bronchoscope down, and pick out all that food. There are bronchoscopies that are elective procedures, though. I mean, pulmonologists will do bronchoscopies for any number of reasons: to see why a patient has a chronic cough, to evaluate a lung tumor. There's probably 50 reasons why I'm not a pulmonologist, but I've done anesthesia for pulmonologists who were evaluating the severity of asthma. I'm trying to think of some other things. I mean, there's a lot of things that pulmonologists do bronchoscopies for that are completely elective procedures. The case in the operating room, that was an emergent issue.
So anytime you're calling a pulmonologist to come do a bronchoscopy,
yeah,
that's not a good situation.
I would say typically no. Yeah,
okay.
That's accurate.
Have you ever seen him called in for a different reason in that circumstance? Or?
Yeah, I haven't personally done it, but there are certainly times if the procedure caused some sort of issue in the lungs, even if it's maybe not emergent. If you're in a big academic center, you might be able to call a pulmonologist and say, hey, I had this weird thing happen during this anesthetic. Can you come check out the lungs in a non-emergent situation? I'd say that's rare, though.
And the other question that we had based on our last episode, we want to answer this one, and then we'll do more Q&A in our next episode. But in an emergency type situation, I'm out to dinner. Yeah. I have steak. I have mashed potatoes. I'm enjoying my dinner. I have a bottle of wine, right? And I'm enjoying my night with my wife. Something happens. I need emergency surgery. What happens then?
Yeah, so what we do for the actual induction and placement of the endotracheal tube, we do what's called a rapid sequence induction. Essentially what that means is we give the medicines in quick succession, and we put the endotracheal tube in as quickly as possible without allowing any time for the patient to vomit. Once that endotracheal tube is in, honestly, if you vomit, not a big deal. Your airway's protected. All I'm going to do is suck the vomit out of the back of your throat. You're fine, right? The issue is when the vomit goes into your airways. So that's a rapid sequence induction. Typically, we use medicines like propofol and succinylcholine, which is a non-depolarizing neuromuscular blocker, causes you to be paralyzed pretty quickly. Put that tube in. Then we also give some medicines preoperatively, intraoperatively, and postoperatively that reduce the acid in your stomach, that reduce the chance that stuff is not going to process through your stomach into your intestines, and then that will sort of slow down or reduce the amount of vomiting.
Sounds like anesthesia in an ER is complicated as hell,
man. Yeah.
And stressful.
Yeah. No, yeah. I mean, acute care anesthesia it can be tough. I mean, you can get procedures that come in where patients are really sick and full stomach, meaning they just had the meal you talked about, and you've got to figure out how to do the anesthetic. So it's tough in acute care settings for sure.
And if it's an elective surgery, we talked about it last time.
Getting canceled. Don't eat.
Don't do it. This has been Going Under, Anesthesia Answered with Dr. Brian Schmutzler. Brian, thanks. And, of course, you can send in your questions on social media and or below here if you're watching this on YouTube. We appreciate all questions, and he'll try to get to all of them.
We try.
We'll see you in the next one.